Dr. Pressman has already introduced me. This is us. You can see us actually in a picture together right there on the master class that we got to do together. But beyond that, just as further introduction, I have the privilege of being one of the leaders at the Child Mind Institute, a nonprofit that has offices in both New York and California, as well as Athens, Greece, and with a focus on youth mental health and with a core pillar of our work being kind of public education. This is just an intro slide that we usually have about Child Mind. For those of you interested, our website, childmind.org, has lots of other information. But we're about a 500-person nonprofit that has clinical practices in New York and San Francisco, school and community programs that extend our services to high-need schools in and around our home offices, robust financial aid and philanthropic backing to help people be able to access care, public education that starts with our website, childmind.org, and also entails free curricula that we've created that I'll talk about in the prevention section of this presentation, as well as all kinds of programs that we've disseminated nationally and globally, and then a science team that focuses on finding objective markers of mental health and learning disorders, neuroscience research, and utilizing digital therapeutics and the digital world for good in youth mental health, while also making sure that we have key messages around things like the overlap between youth mental health and technology that are out there and where parents can take kind of science and science-based and practical kind of advice from our science and education teams. So with that, to introduce a talk like this today, my thinking is it's a real privilege to talk to an audience that likely consists of many providers, medical providers, likely also consists of many of you who are also parents and caregivers, and any of you who work in settings with kids. This is going to be really a presentation that we've created at Child Mind that's centered around helping people to think about the importance of screening, how they can recognize kids who are struggling with some of the most common youth mental health presentations, things that you can give immediately to people in your community for prevention that are all free and available, and then also just some thinking about what evidence-based intervention looks like for youth and how to think about how you make referrals and help people to seek help when you realize that a kid might really be struggling. So that's what I'll try to go through in about the next 45 minutes and leave at least 10 minutes for Dr. Pressman to throw some question and answers that you all might submit through the chat or elsewhere to us. So in terms of screening, let me just say that I'm not terribly talented at PowerPoint. I would think that my talent lies in speaking about the information on a PowerPoint slide, but not necessarily making a slide. So for those of you who are really good at visual design, my slides tend to be very busy. Also in this particular one, I could not figure out how to get the 4 logos of our global team to go away from the bottom left, where our logo is overlaid. Bottom line, this is a slide that our global team and our national teams use as a way of framing the importance of screening. The U.S. Preventive Services Task Force is an independent organization of experts across the country that try to put out guidance for pediatric practices, pediatric mental health and medical health settings around best practices for youth mental health. And so this is just highlighting a few of the papers that this group has put out. If we look toward their recommendations, and this is really where we start with medical practices, what we see the strongest evidence for, and this is across diagnostic categories in youth, many of which I'll talk about in a little more detail later in this presentation, we want to think about the notion of universal and targeted screening. So if we're going to make recommendations to pediatric medical health settings, what do we have the strongest evidence for the need for universal screening? Where do we have the strongest evidence for targeted screening for certain vulnerable populations or at certain developmental stages? And so the strongest evidence through this group is for universal anxiety and depression screening. And what you're going to see on the next slide is that what we really recommend based on the state of the science is that in pediatric practices, we use a few publicly available measures to make sure that we're screening at certain key developmental stages for autism, anxiety, and depression. And then targeted screening is done when a parent or a caregiver might express a particular concern about a child with, again, free and publicly available evidence-based and validated screening measures. So with that, what I'll say is that beyond the anxiety and depression thing, the evidence that we bring to bear on the notion of universal screening for autism comes from the American Academy of Pediatrics, which I'm guessing that a number of our listeners may also be affiliated with. And this is where we look at particular time points where the evidence base is strongest for universal screening for autism spectrum disorders. And this is where we really are focused on this kind of 1.5 and 2 years timing when we can start to engage in early identification and also get kids intervention at an early stage when it can be most helpful. So with that, when we talk about universal mental health screening, this slide is meant to kind of be a guide for pediatric practices in saying, if we're going to take the strength of evidence that says what should we screen for universally, it's these three things. And when we look at when we're beginning to screen for these things, if we're in a practice that serves toddlers between 16 and 30 months, there's a particular publicly available measure that we'd recommend, the MCHAT-R, which, by the way, in 2 slides, you will have links to every measure that I have mentioned, public links that are not behind a paywall with PDFs that can be used in practice. And then for preschoolers and up to early childhood, the screening for ASD would be the CAST. And then in terms of publicly available measures, we tend to favor the RCADS in late childhood and in adolescence, mainly because it is titrated to anxiety and anxious presentations in that kind of late elementary school, early middle school age range, and then can also screen for depression effectively as you move into adolescence. And you'll see in a slide later in this presentation, these are also kind of correlated with the average or the median age of emergence of various mental health difficulties that youth might experience. But this is kind of the universal screening framework where if we can get every medical practice using these three measures and putting them as a kind of addendum on any visit that a kid might have or any, I should say, well visit that a kid might have in these age ranges, this allows us to catch a lot of things where universal screening is indicated. Now, in terms of targeted mental health screening, there are a host of conditions where we want pediatric medical health providers to be thinking, if I hear this particular thing, maybe this is the measure that I have on hand that can be given perhaps at a point later in the visit or as a follow-up or something like that. Where, as you can see kind of in this table, the first concern on the top left is someone saying, I have a concern about my kid's early development, social communication. If you're not already using an autism spectrum disorder universal screener, this is where we would say, let's put the MCHAT or the CAST in, depending on the certain age ranges that a kid is falling into. If we hear a parent say, I have excessive worries, or my kid has excessive worries, or they're really afraid, or they're very shy, or they're persistently sad, that's where the RCADS can come into play if it's not already being used universally. If parents start to talk about symptoms of ADHD, they can't seem to pay attention. They can never sit at circle time. The teacher says they're moving too much. They're too hyperactive or impulsive. They are, engaging in all kinds of negative behaviors. They're aggressive towards siblings. They don't listen to me. The SNAP can be a really easy measure to assess for ADHD symptoms and also to assess for significant behavioral issues. And then if people say that where they're worried about their child's eating, especially as we're looking at that middle school age and emergence into adolescence, we recommend a measure called the SCOFF. And then if folks are really concerned as they get into adolescence that their teenager might be starting to use alcohol or substances, there's an available measure called the CRAFT. Further on targeted mental health screening and some of the most sensitive topics, when we do hear that youth are at risk of harm, or we're hearing that a parent says, I'm concerned they might be cutting themselves or hurting themselves, we use the DISHY. If we hear, I have concerns that they've been through a really traumatic experience and I don't know how they're processing it, they seem really on edge or they seem like they're kind of, avoiding all kinds of reminders of this, that's where you can use the CATS. If we hear about suicidal thinking or behavior, one of the most serious concerns that we hear from parents, we recommend the ASQ. Now, I will say the ASQ, the reason why you heard me laugh is not because suicide is in any way funny. It's more that there are 2 measures that are abbreviated by the ASQ. One is ages and stages, which is a measure for very young children, looking at kind of gross and fine motor, expressive and receptive speech, developmental milestones. And then there's the ASQ, which we've linked to, which is more about suicidal thinking or behavior, where we can help assess that in a very brief interview and figure out how much risk there might be and whether or not we might need to take action. And then lastly, when we get into kind of severe behavioral concerns, say adolescents who might be at risk of physical aggression or violence, that's where we might use the MOAS. So one of the reasons why I run through that quickly is we're going to talk a little more deeply about all kinds of signs and symptoms of youth mental health disorders. But what I want to make sure of is for any medical health provider who might only be listening for the first 7 minutes, I want to give them this right away. This is something where you don't need to know anything more about, the presentation. I don't mean that anybody should sign off at this moment, but we are so focused on the practical at Child Mind that I want to say for anyone who's in a medical setting, if you are thinking, okay, I want to help, bolster my youth mental health practice within this setting. This is the slide that you can refer to later because we are going to send out a PDF of the slide with all these links able to be clickable after this presentation. This is where, as a practice, you have links to the MCHAT, the CAST, and the RCADS for universal screening. And then I've included links to all the measures that I mentioned for targeted screening for various issues. I've also included, just as one measure that I did not include mention of, if for some reason you want a separate and incredibly well-validated publicly available measure for depression, maybe you want to do anxiety using the RCADS, but you're not sure it like as deeply captures, the variability and symptoms of depression. I have also included a link to the PHQ here, which is quite widely used in the field. But this is basically something where any medical practice could create a shared folder on a drive with all of these measures in it, with measures to be given as universal screenings at developmental time points I've outlined already, and then targeted screening depending on what kinds of concerns are heard from parents, that would be well validated and will also help give us a good bit of evidence to speak to parents about the sensitivity of kind of a need for referral. And that will be the final portion of what I talk about today, is kind of how to have those conversations. So the whole point of any presentation like this is that we really think about what it looks like in a medical setting to think about how we can help with youth mental health care while at the same time not overburdening pediatricians and medical professionals in these settings. So our focus is that, at this stage, as we've talked about kind of these universal screenings and targeted screenings, we want pediatricians, we want medical professionals in these settings to be well equipped to observe and assess effectively and with well-validated measures what's going on for kids, and with developmentally appropriate measures titrated to their age range. Beyond that, we want to equip medical professionals with the understanding of major mental health presentations in childhood such that they can communicate to parents about what to be on the lookout for and where there might need to be, further needs to kind of, again, assess a child at a later developmental time point. As we get into this kind of yellow zone, and we think that there might be something going on for a kid, we want to give pediatric primary care providers the information they need to be able to have those tough conversations, even with the brief amount of time they often have with patients, to provide support and validation, to be able to talk about what needs to be monitored, or to be able, when we're really seeing some significant impairment, to guide people effectively to the kind of treatment that could be effective for their child. And I will say that last point about guiding, the last 10 minutes of what I talk about will perhaps be the other most important part of the presentation, because what we find in general is that the awareness of particular evidence-based treatment models for different presentations of youth mental health disorders is not terribly high across our field. And part of that is that it's actually a problem with the field itself, in that when we train child providers, I think the gaps that we see are that if you're a medical provider, you can be trained in Nebraska, Georgia, New Jersey, and you can be given the same training on ways to approach the same medical conditions. Whereas within the field of mental health, it is maddeningly inconsistent, in the sense that training programs across the country may be using models that have much less of an evidence base to help with youth mental health concerns than would be considered effective. And so depending on where you get trained, you might be trained differently in Nebraska, differently in Georgia, and differently in New Jersey, depending on where you've gone to school. And this is where we really want to make sure that folks are aware of what's going to move the dial, and not have parents dropping their kid off at a therapist with a hope that it works for something that isn't really indicated for the particular diagnosis that their child has. So with that, let me dive into kind of the signs and symptoms of common youth mental health presentations, information there. Uh, when we look at youth mental health, an important piece that we want people to think about is the prevalence of youth mental health, and at the same time, how many people actually get treatment. So one particular stat that we want to make sure stays in folks' heads is that 1 in 5 youth suffers from mental health and learning disorder. And this is by far, when we take the combined number of youth suffering with any other condition. We're talking different kinds of allergies. We're talking about really severe medical conditions like childhood cancer, things like that. It's still, if we tally up all those numbers, pales in comparison to the number of youth that will suffer from mental health or learning disorder by the time they reach adulthood. Now, what we want to be sure we're mindful of is that half of those youth who experience a mental health learning disorder will see the onset before age 14, 75% before age 24. And what the research shows us time and time again is that when kids are significantly impacted by a mental health or learning disorder, early intervention is best and can help stop some of the really negative sequelae that comes from kids feeling like instead of being able to kind of support their own mental health and do it with the support of their village, when kids feel like it's their fault or that they're failing or that the mental health issue that they struggle with is something that doesn't really have a solution, that's where we see academic failure. It's where we see rejection from family and friends. It's where we see kids start to turn to more negative developmental consequences later on that we really could prevent if we got them treatment early and well. So that's where we want to understand, first of all, this is common, this is real, and this is treatable, and that early intervention routinely shows these best outcomes. Now, what we see in the research is that a majority of parents will wait a year or more from the time that they believe that something is wrong with their child to the time when they talk to somebody about it or they seek help. 25% of parents wait 2 years or more before they seek help. And that is a long time for a kid to struggle. The way that I kind of address that with parents and families is often by saying, like, look, let's talk about the cost of waiting. If you've got a kid who's anxious, let's talk about the cost of the stress hormones that they are swimming in for a year or two with the level of social anxiety they're feeling, or with the level of OCD symptoms they're struggling with, or feeling like they're trying to control their environment, or with the level of anxiety they have around a particular stimuli or something like that, or they're worried about going to school and trying to avoid it. That is so much suffering. Or with kids who struggle with behavior. Um, if you think about kids who struggle with ADHD or behavior disorders, um, we do studies where we look at the feedback that those kids get. In a given hour, in any classroom, you often see that kids might, with ADHD or a behavioral issue that's untreated, might receive anywhere between 6 and 10 pieces of feedback from adults about how their behavior is off limits. Then, if we take that over the course of, say, we'll go with a 6 hour school day, um, we're looking at something like, anywhere from 36 to 100 pieces of feedback. And over the course of 2 years, 180 days of school, I mean, these are thousands of pieces of feedback that cause you to think to yourself, I am trying, but God, I don't know what I'm supposed to do to be able to make the feedback work. And that is just a lot that kind of complicates things when we can get kids intervention. Another reason to give a talk like this is that when we look at this, research indicates that 81% of parents with concerns talk to their pediatrician. Only 29% say their pediatricians routinely ask about the child's mental health when we look at survey research. So what we know is that you're going to be, if you're a pediatric medical health provider, you are likely to be first point of contact, just because parents are more likely to make those medical health well appointments and not necessarily to think about seeing a mental health professional for a well visit. And at the same time, parents will say to us that it's actually much more rare that people in pediatric medical health settings will ask about mental health. And that's why I start with universal and targeted screening points. This slide illustrates all the different kinds of psychological concerns that we often are assessing for within an intake session as as mental health professionals. So what we're doing is we're going through with parents, and anytime someone comes in with a concern, it is just as important to us to rule in a suspicion of a particular concern that a parent might come with as it is to rule out other things. Because one of the difficulties with a medical model of mental health disorders is that we're not necessarily cleaving mental health at the joints, and we're not necessarily dealing with objective markers. We're dealing with behavioral symptoms that people report. And so if someone says, my child is having difficulty focusing, that could be because they're depressed. It could be because they're anxious. It could be because they have ADHD. It could be because they have a learning issue that is associated with that particular subject. It could be because they've experienced a traumatic event. It could be because they have autism spectrum disorder and they're not exactly sure of how they're supposed to behave, or at least feign interest in certain boring situations, or they might be under the influence of a substance. So I just take that symptom as a way of like saying, if there's a single report of a symptom, unfortunately, it doesn't immediately tell us, oh, this must be it. And all too often, mental health professionals and medical professionals will have a bias where we'll say, okay, well, that sounds like ADHD. So for that reason, we then seek to confirm that diagnosis or deny that diagnosis rather than being able to assess completely for all the types of things that kids might be struggling with. So this is where we want to be thinking about all of these things, but in particular, the things that I'm going to drill down on today that I want us to think about, talking to parents about and being able to look out for with kids are the things that occur most frequently, which is anxiety, ADHD and behavioral concerns, and depression. Those are the things that occur most frequently. And then, for any number of other concerns, of course, I can address in the Q&A what that might appear like or, what you might hear in a report. But I want to make sure I hit the like absolute frequent flyers. So as we think about it, another reason why we really think about universal and targeted kind of screening for these things is that different disorders have different median ages of onset. So anxiety tends to see an earlier age of onset where you might see that a kid is more anxious just around all kinds of different stimuli. And again, this also could be linked back even earlier in development, sometimes to temperament for children, where we see that they have a sort of reactive temperament that looks at newly presented stimuli as a big stressor and something that we should see a lot of stress around. ADHD, the part about it having a median age of onset of age 11 is a little bit kind of a misrepresentation of a sort of bipolar data set, where what we will generally see with ADHD is that kids who have hyperactive impulsive symptoms tend to get diagnosed a little bit earlier than age 11, usually around second or third grade, because that's when academic work really starts to increase, and a lot of the symptoms on that axis of ADHD are considered to be real behavioral challenges affecting a kid's learning. Whereas kids who struggle with inattentive symptoms, these symptoms can perhaps go under the radar for a little bit longer and contribute to a later median age of onset. Mood disorders are extremely correlated with kind of onset of puberty and onset of adolescence and some of the emotional volatility and intensity that happens there. And then with substance use, this tends to have a median age of onset that's also correlated with the presentation of substances in social environments, and then also kids who may already have one or more mental health conditions that have not been successfully treated and thus have led to perhaps a higher risk of substance abuse due to fraying of relationships or academic failure. So, to jump into anxiety and what this looks like, and this is kind of like what we talk about with a parent if we had kind of 3 minutes with them. The reason why we start with anxiety is while anxiety disorders are the most common mental health concerns that parents might bring to us, they also fall along the most easily understandable spectrum in the sense that a lot of anxiety is a normal and adaptive response. It's something that we all experience. But what we're trying to emphasize to parents is that, the tools that we have for dealing with anxiety can work with any anxiety, whether it's anxiety that's non-clinical or subclinical, or anxiety that's posing a clinical problem. And the part we really want to be on guard is when it gets in the way of a child's ability to function. Are they able to go to birthday parties, hang out with peers, go to school without anxiety, work on tests, work on homework, any number of places where childhood anxiety presents. We want to make sure that it's not impairing their ability to have experiences of typical childhood. Now, the thing about anxiety disorders, and this is how we frame kind of treatment, is that what anxiety does is it makes it so you have difficulty tolerating, the uncertainty of a stressor that you're sure it's going to be bad, or you're sure that it's going to be, terrible for you or embarrassing, or it's going to cause a kind of negative emotional state. And what anxiety kind of forces you into is avoidance, a sense of kind of like, how do I make sure I don't encounter this stimuli so that I don't have to feel this way? And another word that's common that we want parents to think about is accommodation. It's that how anxiety gets reinforced is a kid already is going to try to put themselves in the driver's seat as much as possible to avoid the thing that is the cause of their anxiety. But at the same time, what often happens, this is where we tell parents, you're not the problem, you didn't cause the anxiety, but you're the solution. Because all too frequently, parents are trying to help their kid to feel better, so they will accommodate the avoidance of that anxiety as a way of removing that negative emotional state for their kid, when in reality, the treatment for anxiety is graduated exposure. We want to help a kid to be brave in small steps, learn to recognize when they're feeling anxious, learn that they don't have to feel not anxious to be able to actually tolerate a situation. We hope that maybe they can have skills to manage anxiety, but at the end of the day, we don't need somebody to be not anxious in order to be able to confront anxiety. I always give parents in this moment the example that I tend to travel a lot for work and really love the opportunities that I have to kind of go and speak to audiences all around the country. But I hate planes. I've been anxious on planes since I was a young kid, and I'm convinced that it will be the death of me whenever I get on one. But at the same time, I cannot make myself comfortable on a plane. What I have to use my strategies for is to help myself to accept, kind of where I am, to accept that I am uncomfortable, get comfortable with it, and then to do whatever I can to cope with it and get through the experience. But at the end of the day, the purpose of anxiety treatment is not to eliminate anxiety, as we can't. It's a typical emotional experience. The ways that we see anxiety presented in any setting vary. Anxiety has a lot of different things underneath it, and even a disorder that's not listed on this list, obsessive compulsive disorder, which when we talk about our diagnostic and statistical manual, sometimes we consider the idea that OCD might be its own separate category. But the reality is that anxiety can present in all kinds of different ways. Separation anxiety is usually young kids who have real difficulty being away from parents or caregivers. Now, again, this goes on a spectrum. Lots of young kids, when they go into preschool, will cry at separation, but then kind of re-regulate with trusted caregivers in preschool over the course of the day. We're looking at kind of very severe reactions or times when parents say, look, I think it's causing my kid actually too much pain to be separated. So I just don't let them go to school and I don't necessarily leave them with babysitters or anyone else other than me. And that's where you get this kind of impairment that impairs the parent-child dyad as well. We see this in phobias. About 30% of people have at least one phobia, where it can be, animals, it can be situation, it can be environment, but it's really intense fear about that particular thing. It can be social, around peers and in social situations, or worries about being exposed in public or being in front of others. Selective mutism is a particular form of social anxiety where a kid becomes so socially anxious that they refrain from speaking to strangers, sometimes to teachers, sometimes to anybody in their family outside of nuclear relatives, and sometimes refrain from speaking even outside the home. Generalized anxiety, you're talking to one right now. This is, a sense of worry or anxiety about everyday things. And basically, your anxiety is just a well of stuff that can keep you ruminating, keep you up at night, cause you to feel continually stressed about everyday worries. For people with generalized anxiety, it's reached a point in the continuum where maybe it impairs your ability to function in certain situations. Panic disorder, which, entails these kind of very severe anxiety reactions of intense fear and panic attacks that may be somewhat predictable or may be unpredictable. And we have to figure out kind of how to get our bodies to be ready for those experiences and figure out how to kind of make it through. When we talk about anxiety as it presents in pediatric medical contexts, what we expect to hear, kind of taking it away from the diagnostic terms, is parents saying, look, my kid has a lot of difficulty separating a drop off, or I can't leave them with a babysitter, or they just cry the entire time. One of the reasons why we talk about frequent visits to the nurse's office, because often a symptom of anxiety is somatic pain. So a kid will start talking about stomach aches or aches of some sort. And that's oftentimes we would think of like a kind of bodily experience of emotion that, is something that's not as often talked about in Western cultures as we would like it to, but one that's often an indicator of anxiety for kids. We'll hear about kids' difficulties in various situations in school, participating in class, being in front of the class, talking. I mean, my 6-year-old daughter, for example, at one point did not want to be the kid of the day who talks about the weather of the day of the week because that made her feel pretty anxious. Going to the bathroom at school, eating in the cafeteria. We'll hear about perfectionism. So kids who don't want to initiate a task unless they can do it well, or they know exactly the right way to do it, or when they're doing a task, if they don't feel like they're doing it the right way, it becomes a really, intense experience. Um, we see a lot of this is one of the aspects of accommodation that we often see with anxiety, where a kid is just asking questions over and over. Is it okay if I do this? Is it okay if I do this? And we have adults who are saying, yes, you do not need to keep asking permission to do X or Y. Or, honey, you don't need to check with me about each thing. Like, it's okay. Or a kid who's looking for reassurance, seeking around the fear. When we go to this friend's house, is there gonna be a dog? Is there gonna be a dog? Is there gonna be a dog? Is the dog nice? How big is the dog? What does the dog look like? And where we can see how that anxiety works. And then beyond that, we'll say to parents to look out for situations where a kid feels really overwhelmed or tearful, just thinking about a future event that they kind of don't know about. Whether it's a social gathering they're going to, or a lesson that you're taking them to, or a new extracurricular activity, any number of things where we can say, like, maybe we need to help this kid a little bit more to kind of unlock their bravery and perhaps not catastrophize about certain things. I will also say anxiety can present as a behavioral concern because some kids will be really anxious about a particular situation. And the best way that they find to get their parents to actually accommodate that anxiety is to throw a tantrum or to try to, disobey the parent or not follow certain commands. Maybe they don't have the words for the fact that they're so nervous to go to a friend's house. So instead, right before they go to the friend's house, they throw a fit, throw all their clothes on the floor, and make their parent, take away the play date that they had. Going to a next common presentation. So I said I'm talking about anxiety, depression, ADHD here. Um, something that we really want to make sure people are on the lookout for, particularly as we get into late middle school years and in adolescence, is looking at symptoms of depression. Now, the symptoms of depression are widely varied, and the reality is that you can have hundreds of combinations of these symptoms and still have depression. So we want people to realize like there's no one way that depression looks, and it's really important for us to be thinking about all these different things that are asked about in, say, the RCADS or in the PHQ. So one of the first things that we want to highlight with depression is that the hallmark symptom is either sadness or irritability. And that's something that's really important to think about with youth diagnoses, is that sometimes irritability and anger, which is often, reported by parents of teenagers, is actually the dominant emotion in a kid who is feeling or is experiencing a major depressive episode. So we're not just asking about sadness, we're also asking about irritability. Beyond that, we're asking also about anhedonia, which is a fancy term for not wanting to do the things that a kid has previously enjoyed. They just kind of, it's this kind of taste like sand feel where a kid reports that even if they liked French club or they liked playing the violin or they liked playing soccer, now it just doesn't have the same luster. And they haven't seemed to pivot to new interests. It's more that it just doesn't feel the same. We ask about eating and sleeping because that can be a real indicator of mood change or changes in energy. We'll ask about attention because that is also a symptom of depression. And we really want to get into the self concept. We want to understand how the person is thinking about themselves. Are they thinking about, feeling like they're stupid or they can't succeed in school or none of their friends like them or no one would worry about it if they were gone or they feel awful about the kind of person they are or something like that. And then we want to really assess about whether or not they might be thinking about death or they might be thinking about suicide or they might be thinking the world will be better without me. I should just die, those types of things. And that's a key point because it is one of the most significant things that we as mental health professionals assess for. One thing that I want to emphasize across any provider audience that I get to speak to, talking about suicide does not increase the chance that anyone will harm themselves. And I'm going to say that again. Talking about suicide does not increase the chance that anyone will harm themselves, but not talking about it can be fatal. So this is where we want to make sure we're asking adolescents not only about depression, but also about suicidality. Are you having thoughts of harming yourself? Have you ever thought about dying? Have you ever thought about the world being better off with you dead? Have you ever thought about the way you would die? It's really important to assess for those particular things because, again, that is one of the most serious things that someone can be experiencing, and we want to put a safety plan in place around that person and get them treatment immediately. Beyond that, what we'll hear from parents as kind of like red flags that we would think of as being indicative of a teenager or even a child being in the midst of a depressive episode are again these kind of changes where a parent will notice a change in academic performance or a change in the way that they're attending school or withdrawal from their activities or refusal around schoolwork or they are increasingly irritable or they just don't seem to have energy to do anything or they don't seem to be interested or absorbed in things they saw before. Any of those things that we hear, we want to think, okay, maybe I take a next step in assessing for the presence of certain symptoms here. Going to our last most common category, ADHD. ADHD has two axes of symptoms, inattentive symptoms and hyperactive impulsive symptoms. And you can be diagnosed with ADHD if you have 6 of 9 of the inattentive symptoms, 6 out of 9 of the hyperactive impulsive symptoms, or you satisfy 6 out of 9 on both axes. That governs your presentation. You can have ADHD inattentive presentation alone, ADHD hyperactive impulsive presentation, which is actually quite rare, alone, or ADHD combined presentation, both of these symptoms. When we look at the diagnosis of these things, we're assessing for both of these categories of symptoms. And also because ADHD is considered more of a brain-based mental health condition, the reason why we're assessing across settings is that provides the differential between this and what we'd think of as behavioral issues. Because if, for example, a parent says, well, look, I'm reporting difficulties of behavior, not following my directions, not seeming to respect me, interrupting and yelling at me and things like that. and they say it's only happening at home, but teachers are not seeing any sign of these symptoms at school, then our sense is that this might not be biologically based like ADHD is. It might be something that is more environmental and where we need behavioral interventions in the environment where these symptoms are presenting. One important thing about ADHD is the diagnosis has evolved a lot. It will likely continue to evolve. My guess is within the next 2 decades, it'll have a name something like prefrontal disorder of attentional regulation or something like that. But when we look at ADHD, we've moved away from, first of all, the term ADD. The condition is called ADHD. You can have it with or without hyperactive impulsive symptoms, but ADD hasn't existed since about the turn of the millennium. And beyond that, there are no longer subtypes because what researchers figured out was that when you tell people that they have the inattentive subtype, that did not tend to be as reliable across development. People might switch in their presentation, whereas the ADHD diagnosis was reliable. So in that sense, we want to tell people there's kind of a presentation of symptoms. Um, and the ADHD diagnosis is likely to be reliable, and 75% of folks are likely to retain that diagnosis into adulthood. But we want to make sure that if someone's diagnosed with ADHD combined type at kind of an early age, and later on we say, well, I think this is ADHD and attentive presentation, we're not necessarily making them confused or having them reduce their, confidence in the diagnosis. On the right are just some major kind of commonly reported concerns that are associated with these symptoms, where parents will say, look, I don't know what this is. It's like we're reinventing the wheel every day. They cannot complete daily routines. They can't follow directions on just kind of the mundane stuff, at home. Teachers saying that they really can't complete their assignments in school, or parents saying it takes hours to be able to complete the homework with 17 different distracting activities. Parents will say, I don't understand. They can, play video games for 4 hours, but they can't focus on their English assignment for 3 minutes. That's that gravitation toward reinforcing activities, because what ADHD really is a disorder of focus on non-novel, repetitive, or mundane activities. What we'll also see as kind of associated difficulties that are often indicated with ADHD are kids who have difficulties maintaining peer relationships because they can't seem to focus on a lot of the social cues, challenges with sleep and getting enough rest, difficulties with organizational skills. And the last piece that I just want to say about ADHD is that there's two notes kind of on female presentation of ADHD because so many more males are diagnosed with ADHD. First of all, females may be more likely to be diagnosed with the inattentive presentation um, because those symptoms are, focused on kind of inattention, distractibility, carelessness, organizational skills. A lot of times people interpret those symptoms based around female gender roles. She must be anxious, she must be sad, she must be depressed. That must be why she can't focus. And so this ends up getting overlooked to some degree when we really want to ask questions about ADHD because we don't want to necessarily assume that someone's going through an emotional crisis, but rather, understanding the symptoms in that context and knowing that girls definitely do have ADHD, even if the presentation might be somewhat different. The last thing I'll go through is I know I said I want to go through the things that are most, common in childhood. I just want to say a couple things about a couple other diagnostic categories. First is learning difficulties. Uh, when we're looking at this, I always want to follow a talk where I mention ADHD with learning difficulties because if it's in a specific subject, like if it's around reading or it's around writing or it's around math, in early elementary school, uh, that may be a place where we think about a deeper evaluation. So with anxiety, depression, and ADHD, most of the time I'm telling, medical providers, this is a moment where you can refer to any mental health professional for a diagnostic evaluation. If it's actually with a specific subject, or it's around speech and language, or it's something where parents say, look, it's a lot of organizational, executive functioning, challenges. These are the moments where I want medical professionals to be thinking neuropsychological evaluation. Like, let's go one level deeper than a diagnostic intake evaluation, where we really want to make sure that we're not saying this kid has difficulty focusing or with ADHD. We're testing out whether or not this could be a disorder of written expression, a learning disorder associated with writing and or a learning disorder associated with math. So whenever you hear about troubles in school, if it is around a particular subject where we see like real differences in performance between certain subjects, that's where I do say like we need kind of another level beyond, say, just the typical diagnostic evaluation of a mental health professional. And we don't want to miss a learning disorder, particularly in elementary school, because we have great interventions for kids who are struggling with this, but they need to happen early. We're talking early elementary school grades, first grade, second grade, third grade. So With that, I know I've given a kind of run through of some of the most common diagnostic categories. Let me say this, and I'm trying to do a lot in this presentation, I know. Um, what we've talked about so far is screening recommendations for medical practices. Secondly, what you might hear from parents around the top three, as and with an addendum, kind of ways of presenting with mental health difficulties in youth. The next thing that I want to hit on is just kind of the general speech that I would love for every provider in the country to be able to give parents. And it's related to the next three slides. It's basically saying to a parent whether or not your child has a mental health disorder or not. From day one, there are certain things we can think of as the drivers of developmental success and wellness for your child. And there are certain things we can think of as emotional skills and mental health skill building that can help to mitigate the effects of any mental health and learning disorder that they might suffer from. You might not be able to prevent its onset, but you can equip them with tools that allow for reduction in suffering and better ability to attack that mental health and learning disorder when it happens. So that's what the next three slides are about. The first is when parents come in, and this is a common thing for all of us in the field, that parents come in, they say, look, I'm so concerned about X or Y. It's my kid's screens, it's, this particular thing. Like, and they're really hyper focused on one area of difficulty that a kid might be having. I always want to show this slide where I say, like, look, if we're going to take a 30,000-foot view of your kid's wellness, I really want to understand how they're attending school and how they're engaged there. I want to understand how they're engaged with homework or whatever homework they have. I want to understand what kind of face-to-face time they're spending with friends and family and the quality of those interactions. I want to understand their sleep, how much they're moving their body, their diet and their hydration, some of the basic building blocks of wellness. I do want to understand the consideration of any mental health vulnerability in their family or in their family of origin or any environmental vulnerabilities that might lead to mental health difficulty. I do want to understand their screen use and I want to differentiate based off of the research between certain areas of screen use that we've mapped that might be risky or harmful, and certain other screen use that might be within, say, recommendations that we as mental health professionals or others at Common Sense Media, the Child Mind Institute, the American Academy of Pediatrics would recommend, where use in certain doses and certain ages of screens for information or social connection or entertainment or relaxation might still be very much less risky than other screen-based activities. I want to understand, is the kid cultivating at least a hobby or an extracurricular? And I want to understand how they're contributing to the household or what your thoughts are about, especially as we get in the teenage years, employment or how they might be getting experience in kind of the working world. And when we look at all those factors together, it gives us a picture of not just this kind of area of concern or crisis of the week, but things, usually any line of questioning around this gives us at least a few things perhaps to focus on or engage with as a checklist around promoting youth wellness. The other thing that I'll highlight is if there's anything that I want to give parents from day one, it's saying, look, there is not a manual, unfortunately, for building your kid's mental health literacy or making sure that every kid can have the same emotional skills that help to decrease the severity of mental health challenges. But there are resources out there that can at least do a pretty good job if we consume them at some level with our kids, talk about them, and make them part of our daily practice. And so I'll often show parents the graphic like this, where I'll say, look, these are skills drawn from social emotional curricula, cognitive behavioral therapy, dialectical behavioral therapy, all the best of prevention models and second and third wave psychological treatments, where we'd say, whether or not you suffer from a mental health or learning disorder, these are things that can help. So it's being able to engage in feelings identification, having problem solving skills, knowing what skills you can use for relaxation or stress relief, thinking about how you manage big emotions, whether or not you're just riding the wave or trying to decrease that emotion itself, thinking about how you manage your thoughts and how you talk to yourself, your self-talk, and your cognitions, thinking about how you engage in pro-social behaviors in your community, and then thinking about mindfulness and your level of presence and grounding in the life experiences you have and the things that either bring you joy or the things you want to focus on. As something that's a resource for all of you to provide to any kid you work with, the Child Mind Institute has developed a curriculum focused on teaching those exact skills that is freely available on our website with kid-facing videos for preschool, elementary school, middle school, and high school populations, as well as a set of parent-facing videos on the 20 most important topics in 21st century parenting. All these resources are free. They all come with written guides. They all can be self-guided, and they are all at the link that will be included at the bottom of this slide on childmind.org. the Thriving Kids projects, and that will be, sent out after this presentation. But if you were looking for one single thing, you can say, go to this website, find the curriculum that is associated with your child, and you will find videos, made for that age range that you can watch with your child and then talk about the practice of those skills, whether your child suffers from mental health or learning disorder or not. And now we get to the last and most important part of the presentation before I will definitely try to take a few questions. When to refer and how to talk about it. So what we tell anyone is that, a lot of these symptoms can be typical. Kids can have moments where they're bored by a teacher and not focusing. Kids can have moments when they're sad for a few days, of course. Kids can have moments when they're anxious about any new experience, those types of things, or they can have difficulties with friends. What we want to be thinking about when we're making a diagnosis is usually associated with this kind of acronym, FIDI. It's that we want to know how frequent these things are happening, how intense they are when they do, how long they've been happening, and whether or not they impair a child's functioning. Without those particular things, without knowing that they've been happening for a while, they're happening frequently, that they're intense, they're impaired, it'd be unlikely that someone would get a diagnosis. We might still provide treatment because at the end of the day, even subclinical concerns, we might be able to help a kid be more comfortable in certain situations, or help a kid to be able to find tools that help them focus in school, or help a kid to be able to have ways of working on big feelings that they might be having, that help them to feel like they're equipped for some of the big situations that they would encounter. But in general, this is when we're thinking about the need to refer, is if parents are reporting this and it seems outside of this developmental age range, it seems like it's really getting in the way and impairing them, and it kind of is associated with these factors, then we'd say, look, for this reason, I do want to figure out how to find you a mental health professional that can give a larger diagnostic assessment, or if there's concerns about the kid's learning, a neuropsychological evaluation that can really help us to get a handle on this and have a path forward. When we're talking about this with parents, this is generally what I think of anytime, and this is something I think happens for a lot of us in the field. Anytime anybody finds out that I'm a psychologist, I usually get approached at any social gathering and they'll say, can I talk to you about my kid for a second? This is in most places. And I just think about moving through the same kind of conversation that I'd have with a parent who is concerned about their child, but also concerned about treatment, pathologizing, or labeling their kid. So I'd say first, I want to validate your concerns. I'm really glad you spoke to me. I'm really glad you're thinking about this. God, you're so devoted to making sure that you're supporting your kid. That's the first thing. Secondly, I know how hard it is to talk about this. The stigma is real. It's hard. It's hard to talk about this to other parents. It's hard to talk about this to people in the community. It's hard even for mental health professionals to feel like they can talk about this because the stigma is very real of getting your kid labeled, of feeling like they might feel worse about themselves for these types of things, any number of things. So we want to praise that courage for speaking about this stuff and really seeking help. We want to highlight the value of early intervention. It's also really good you're coming to me about this as soon as you noticed it or as early as possible because it is better when we get there early. Next thing, especially for somebody who might not be doing the assessment, let's take a look at this together. Let's take a collaborative, investigative approach. Like you don't have to have the answer in that moment. You don't have to be able to say, yes, you're right, your kid has autism. Instead, it needs to be something where we say, like, look, I want to take a step back. I want to assess for everything because you might have a suspicion that your kid has something because you did an internet search at 2 o'clock in the morning. But let's really take a look at everything it could be, rule things in, rule things out, take a practice diagnostic picture. Then what you want to do is express confidence that you're going to find support for that family. I really do believe that no matter what this is, we can find somebody who is expert in this and can help you with intervention on your behalf. And the next slide, which I know Elisa's coming on camera because she wants to do questions. The next slide is where I demystify what treatment looks like. And I can talk about that in a second. And I will say that the last link on this slide is just that we have an entire article on childmind.org, which you can Google that title as well, talking about the trials and tribulations of finding a mental health professional, finding someone who's covered by your insurance, finding someone who's titrated to your kid's presentation. And so we want to make sure that people have that resource and are able to help parents and guide them to a resource that can help them find treatment. With that, I know that I probably have an opportunity with the questions asked to demystify what treatment looks like. So perhaps we should move to questions.
I'm sorry for popping in too early because I think that everybody wants to hear that slide.
Well, I figured that was a cue. Okay, got it. Then I will demystify here. So, what I want to highlight related to youth mental health intervention, and I'll do this for 3 minutes, and then promise we'll take questions, is that what I've done here is I've made a very busy slide, and this is my own work. don't like using AI for stuff, but like, I'm trying to like, illustrate this. It's that what I want people to realize is that when we look at intervention options for youth, a lot of times we're considering is, okay, once we have the diagnosis, what's the most evidence-based combo of interventions? Is it involving a child and adolescent psychiatrist? Is it doing parent and caregiver coaching around this particular thing and helping the parent to be the agent of change in the other 6 days and 23 hours a week outside of the 1 hour that we're having a session? Is it consulting with a child's school? Is it doing some individual therapy with the child with particular strategies adapted to that diagnostic presentation? Maybe it's CBT, maybe it's exposure, maybe it's DBT. Do we need to do some additional peer and social skills interventions? And is there a reason maybe to do some organizational skills coaching or something like that around, academic work? What you'll notice on this list is that that is the list of the most evidence-based child and adolescent treatments. Neurofeedback's not on there. Dietary changes are not on there. Exercise is not on there. Individual play therapy is not on there. And there are reasons why each of those is not on there, and that's that they either don't rise to the level of evidence or they are not targeted enough to truly help with symptom reduction in these cases. And this is where it's most important because this is something that hurts us as a field. I do not necessarily have difficulty with people who do play therapy for youth when that play therapy is centered around emotion knowledge, getting a handle on kind of understanding your own feelings, exploring what your feelings might be, things like that. If a kid has an actual diagnosis listed on the left, play therapy is not something I'd recommend. The reality is, even in any session with a kid, we might still, in an individual session, play a game or do something fun, but we're not playing and then trying to interpret the child's play to them as a treatment. That is not effective. So when we're thinking about anxiety, I'm thinking, is it severe enough to need meds? How can we use parent and caregiver coaching? Because there's a lot of research showing that parent and caregiver coaching can actually be even more highly effective than having the kid in individual therapy. Does their school need to know about what we're trying to do? And what's the role of individual exposures and working with a kid on gradually facing their fears? With ADHD, I'm again thinking, do we need meds in this case? And what's the parent level of trepidation? When we're talking about behaviors, the most evidence-based approach is behavioral parent training around ADHD behaviors and other associated behaviors. We're usually consulting to a school about support, and we're often thinking about associated areas, like do they need help with friends or organizational skills. With behavior, the parents and the teachers are the most effective mode of intervention. It is not necessarily seeing the kid individually, and I know that's always kind of tough to hear. And with depression, we're often thinking about how to help parents and caregivers to be aware of how they can support the child, even as we might be using an evidence-based approach with depression, like CBT or DBT, individually with a kid.